So good afternoon, everyone. Respected seniors, faculty, dear colleagues and friends. It is truly an honor to welcome you all here this afternoon. We are privileged to have amidst us here the stalwarts of reproductive medicine, mentors whose work has shaped protocols, influenced practice patterns, and inspired many of us sitting here. IVF today represents far more than a lab technique. It stands for precision, personalization, innovation, and responsibility. As the science advances rapidly, meetings like this allow us to reflect, refine, and strengthen what we can carry back to the clinics. As someone from the slightly younger generation of practitioners, I see today not just as a scientific meeting, but as a bridge between experience and innovation. Over the next few hours, we hope to engage in discussions that are practical, evidence-based, and clinically relevant. Discussions that we can take back to our OPDs and our IVF labs, and most importantly, to the couples who trust us with their hopes. With that, I welcome you all and declare the conference open. I would like to welcome Dr. Navneet now to take on the inauguration.
Thank you, Mohit. Now we are about to commence our event with traditional and auspicious lighting of lamp, but digitally, a symbol of knowledge, wisdom, and seek blessings of Vignaharta God Ganesha. For the same, I would invite our President, Dr. Nitin Shah sir, our Secretary, Dr. Bela Bhatt madam, our Treasurer, Dr. Jayanti Kamath, the convener of the program, Dr. Mohit Sarogi, our founder, trustees, Dr. Rajendra Sarogi sir and Dr. S.N. Agrawal sir, and our guests of honor, Dr. Rishikesh Pai and Dr. Nandita madam. Thank you so much. Yes, there's a visual. We have started it. Everyone is there.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Welcome everyone for this beautiful conference today organized by AFG for the IVF Symposium. We would like to begin the scientific program today on this beautiful Sunday afternoon with a panel discussion on decoding the recurrent implantation failures. We would like to introduce the moderators for today's first session. Dr. Shrutika Thakkar, she is the Medical Director, Medansh Multispecialty Hospital and IVF Center, Youth Council member, MOGS since 2015, Yuva lead since 2020-21. She has won multiple awards in various conferences and has contributed to many chapters.
Dr. Sheetal Savankar, Director of Visa IVF and Fertility Center and Managing Committee member from 2023 to 2025. She's a recipient of MOGS RD Pandit essay writing on reproductive health and wealth and several other awards as we can see here. Her special interests lie in mild stimulation in poor responders and RIF.
Now we would like to introduce the experts for the today's panel. I would like to call upon Dr. Nandita Palchetkar ma'am. She is an eminent IVF specialist with more than 30 years of experience, medical director, Bloom IVF. She requires no introduction. Her list of awards and publications is never ending. Please, ma'am.
We'd also like to welcome Dr. Sunita More. She's a senior consultant obstetrician and gynecologist and fertility specialist with over 2 decades of experience in comprehensive women's healthcare. She's known for her protocol-driven, ethical and patient-focused obstetric and gynecological care. Welcome, ma'am.
We would like to welcome Dr. Mohan Kadam sir. He's senior, he's from St. G.S. Medical College, KM Hospital. He is a gold medalist, member of AFG, one of the founder members of AFG. Please, sir. We would also like to call upon the panelist for today's session.
Dr. Uday Zogrekar, consultant obstetrician and gynecologist, practicing for over 25 years at Virar and a keen interest in IVF and operative obstetrics. Welcome, sir.
Dr. Shrutika Parekh ma'am, she is the director and fertility consultant at Shruti Parekh ma'am, she is director and fertility consultant at INI Hospital. Welcome, ma'am.
Dr. Dharam Shah, IVF specialist, director, Mumbai Fertility Clinic and IVF Center. Welcome.
Dr. Sargam Soni ma'am, she is the consulting obstetrician and infertility specialist in Malad, founder director of Sinest Hospital, Mumbai.
Dr. Ankesh Sahitya sir, obstetrician, gynecologist, sexologist and endoscopic surgeon. Welcome.
Dr. Dhruv Gohil, he is advanced laparoscopic hysteroscopic surgeon and practicing right from in Malad, Goregaon area. Welcome, sir.
Dr. Radhika Seth, medical director of Luma Fertility in Bandra. She has several academic honors. Welcome, ma'am.
Like to welcome Dr. Ashlesha Sankhe ma'am. She is a consultant practicing in Andheri area since past 20 years. She is the managing director of attached with Max Super Specialty Hospital, Cloud9 and Surya Hospital. Please welcome ma'am. Now we would like to begin the session. I would like the moderators to take up, please.
Thank you, Saurabh and Maitri, for the introduction. So before we start, so good afternoon, everyone. Recurrent implantation failure remains one of the most frustrating and emotionally draining challenges in IVF, both for patients and for clinicians. Despite excellent embryos and excellent lab conditions, sometimes whatever you try, it still doesn't happen. The patient does not conceive, pushing us to re-examine what we may be missing. So today's panel is not about adding more interventions, but about thinking better, smarter, and more selectively. Let's begin.
So as we know, there's no greater agony than bearing an untold story inside of you, and that is what we are going to discuss today, about the factors that affect implantation, about how the embryo is the right seed that needs the right soil for implantation, and what are the essential factors, systemic as well as local. I request all the panelists, we are very short of time for such a vast topic, so keep your answers brief and to the point so that we can have a really nice discussion for the benefit of the audience.
So whenever we think about a repeated failure, so what do you think is IVF? So RIF is similar to repeated IVF failures, or is it recurrent implantation failure? Any of you can take a question.
So sorry, I'm going ahead. Huh? So if you've had a failure to achieve a clinical pregnancy after 2 or 3, I would say 3 attempts of embryo transfer, I would call that as implantation failure.
So the definition of RIF has been largely controversial simply because there are so many other confounding factors in every individual case that it would be injustice to our patients to say exactly what number. So 2026 ESHRE committee basically now proposes that you need a cumulative implantation chance of at least 60% for that specific patient.
Absolutely.
Where embryos that are seemingly viable are not implanting, but the exact number of embryo transfers cannot be determined because it depends on whether you do blastocyst, cleavage, how many embryos, single, multiple, PG tested, non-tested. So the current recommendation is if you feel that she's failed enough to warrant further investigation,
you can go ahead.
Call them RIF.
So basically the previous definition was something else where they specified the number of embryos and the number of transfers. But the new ESHRE guidelines say that it is not the number which is specific or the quality. It is a compounding factor where you see the implantation rate as well as the age of the patient. Because obviously a 40-year-old might not have the same implantation as a 25-year-old. So correctly said, Dharam.
Subset of recurrent IVF failures.
Yes.
Because IVF failures could be due to other reasons also, like poor egg quality, poor embryo quality, etc.
Even the cycle might not happen or the embryos might not be created also, absolutely.
And can any of you all tell that how this ESHRE 2026 guidelines is varied from the earlier definition? There's some emphasis on the quality of the embryos. What specifically? PGT, any views on that? See, when we are speaking about the definition of RIF and the quality of embryos is spoken about, is PGT also important when we're talking about that?
Yeah, so in the present ESHRE guidelines, I think it does say that 2 euploid embryo transfers failing, regardless of the age of the patient, would be recurrent implantation.
So that's a move different from whatever was happening previously. There is a lot of emphasis on having euploid embryos being transferred. Can somebody tell me also about what is implantation rate?
The number of embryos you see have implanted after an embryo transfer.
Actually, it's a ratio.
Right.
Number of sacs that you see on the ultrasound divided by the number of embryos that have been transferred.
Yeah, so as
per
against
embryo
clinical
transfer.
pregnancy rate, where we are thinking about pregnancy rate per transfer, it is per embryo year. And how is it important? So then do we take biochemical pregnancy also in this implantation rate?
Not possible because in biochemical you don't see how many sacs there.
Absolutely. So that is one thing which is very different when we are calculating. So rather implantation rate is probably the right way of giving a success rate rather than saying just false.
But to just add on, latest ESHRE also says that even if the pregnancy is like even the beta HCG is positive, even that's considered as
so that is one of the misnomers where the recent thing is only emphasizing on positive beta HCG rather than even thinking about SAC or viability or anything like that.
So we would start with the case study. She is Mrs. TRP, who's 41-year-old, married since 4 years. Done 3 IVF cycles at a major IVF chain in the city. They don't give any indoor papers, so the patient has no documents to describe the previous cycles, only prescriptions. Recombinant FSH and HMG cycles have been done. Antagonist protocol each time. 2 fresh cycles of ET and 1 frozen embryo transfer was done, followed by thaw ET. Patient has no idea of whether the embryos were day 3 or day 5. They seem to be mentioned blastocyst but not sure. No idea about the quality of the embryos or the oocytes. Conceived in none, never seen 2 pink lines. Patient is now financially exhausted. Dr. Saab, you are my last hope. Does this couple have RIF? Maybe we can start with Ritu.
Sorry, Sheetal, can we have this monitor on? It's getting a little difficult.
Okay.
Yeah, I mean, sorry, yeah.
Ritu is you. Yes. एक chair please दे देना. मैम ma'am, till that time that the screen starts, ma'am, what is your take? Nandita ma'am, on RIF, what is your experience?
Hi. Yeah. RIF is something that we are dealing with a lot. You know, most of the patients come with failures because I think the simple ones really get pregnant, you know, faster, easier, and then the difficult ones really land up. So basically we do know that most of the times RIF is because of the embryo. You know, the embryo being aneuploid and all. So that is one of the things that we can rule out, that the embryo is euploid. You can do a PGTA. The other thing that I'm finding a lot of it in common is low ovarian reserve. You know, again, that amounts to the same thing, that the eggs may be aneuploid, the quality may not be good, and that's why you're getting it, and you don't get enough. Yes. The other point is the uterus, obviously. I think you're going to cover everything.
But ma'am, your
so let them talk and we'll add to it.
Yes.
Okay, so what I'd like to add in that case specifically is that, see, RIF as an entity was supposed to be made for patients with unexplained failures. Now here we all know what the failure reason is. That woman is 41 years old, and we know that if you use AI models like IVF Predict, the number of blastocysts that woman may need to give her a reasonable chance of pregnancy is going to be over 20 blastocysts without PGT testing. So in such a patient, I think it's very important to counsel her that even if she does multiple IVF cycles, the odds of getting pregnant at 41 is going to be very, very low. And so this patient will not remain an RIF patient the moment you switch to third-party reproduction, like egg donation for her.
So I think that's very good. Can I add over here? You know, I agree with you totally, ma'am. The only thing is also at this age, you should do extensive testing, because it should not be that we're losing out on a good embryo because of some other cause of RIF. So I personally feel even if she's 41, we do get a lot of patients who are pregnant. She should be tested for all the other causes of, you know, RIF at the same time, so that you don't waste her genetic material. It's very, very important.
Point well taken, ma'am, that rather than just labeling somebody as RIF just because 3 embryo transfers have failed, we should fine comb through all the factors. It should not be that in the absence of dwelling deep into the factors, we have just labeled somebody wrongly as RIF. But after how many attempts would, Dr. Radhika, after how many attempts would you like to investigate a person more deeply? After 2 failed attempts. At your center, if it is at various other centers, you are not sure, records are not available, then what do you do?
If records are not available, we'll have to check everything right from the first, as soon as they enter. I mean, as soon as we see them first. But if records are available, then and everything seems fine, then after 2 failed.
And what are your top 3 go-to tests that you would do? Like right after having a patient with 2 recurrent implantation failures? Yeah, for fine combing, like more deep dive.
This patient basically because she's 41.
I think records will get when you request for records. I think one should be given records, and that is something which is law abiding in fact.
So now with the ART registry, I think we are not left with any chance.
We'll have to put everything.
That is
So Shraddhika, I don't believe that if the patient comes to you even without records, you still have to investigate the patient as RIF, because that patient has already exhausted emotionally, financially, mentally, everything. You as a treating physician cannot leave any stone unturned at a 4th attempt. Of the patient. We are not talking scientifically and medically over here. We are talking the patient's already spent for 3 cycles.
Right.
We owe it to the patient to look at everything before we do the next cycle.
So what I'd like to add here is that it's whenever we tell patients that okay fine, I'm going to investigate after the 3rd and 4th cycle, I'm sure all my colleagues will agree that most patients will ask you that why wasn't this done earlier. So it's very important to try to inform the patient right at the very outset that these are the few things that we should probably do, and instead of waiting for the 4th cycle, basic tests should be done at the start.
I think there is a way to communicate saying that you do not kind of draw a cannonball when you can actually do things with a bullet, right? So you have to explain to the patient that the bullet has already been used. Now you're here with me after the bullet has been used, and now I'm going to take out the cannonball. So that's the first conversation that you have with the patient.
Okay, so we would like to invite Dr.
No, these cannot be universalized, I think, and two is little too harsh for the patient.
No,
And the type of investigation that you will end up for RIF.
I'm saying this is how you.
Yeah. Yeah, but the kind of investigations you'll end up with RIF is phenomenal. You'll end up spending another.
In fact, there are so
That
sometimes.
is one thing. At the end of the investigation, you are back to square one most of the times.
Yeah, in fact, so many times
I
patients
think
come
that's
with
a
loads
wonderful
and
point.
loads of files with so many testings that they've done, all the kind of immunological tests, and you are like, what do you look? Because patient is also frustrated. So I understand that has to be a little
And again,
limit.
I want to add two or more failures. If you term, you must know what is the quality of embryo which has been transferred.
Absolutely, yeah.
So morphologically, a good quality embryo, D3 or D5, 1, 2 or one single embryo, that's something very important for you to really understand, and then only you can probably investigate or work up this patient after 2 successive phases.
We would also like to invite Dr. Mukesh Agarwal. He's joined us. So yeah.
And Dr. Radhika, what are your top 3 bullets now? I am coming back to my original question. What are your top 3 bullets? I don't show you that. I'm sure you do.
First, probably in this particular case, for example, if she is not on a 3D USG pelvis, I would do that. A hysteroscopy.
Okay, but a 3D pelvis and a hysteroscopy?
No, I think so. Basically, 3D USG pelvis generally suffices. Most of these girls have already done hysteroscopies. So if she is not done a hysteroscopy, that would be my first choice. Also, looking into the male factor.
Yes.
Yeah, more deeply. So one is sperm morphology and second is the sperm DFI.
Dana mentioned something about IVF predict. Can you tell us a little bit more about this algorithm?
No, so I haven't really used it very often myself, but I know that the idea is to try and calculate what the probability of patients' pregnancy will be per transfer.
So how many
But what
embryos have
parameters
you
they use,
tried?
I'm not.
So how many embryos you've transferred, etc., etc. Yeah.
So IVF predict is a kind of prediction score or a model. So there are many such models which are algorithms. So based on different factors. So maternal factor, age, BMI, how many cycles were done, what were the embryos, were they day 3, were they day 5, what is the success rate of that clinic. So multiple parameters and based
I
on
would
that.
also,
Yeah.
I would want to put, I would also put emphasis, as much as we would do hysteroscopy is the gold standard, but I would also want to evaluate her blood parameters, including a baseline free T3, free T4 TSH. Vitamin D, low vitamin D has proven to be really important in taking control of the release of the harmful microRNAs. Thirdly, I just had this patient last week. She'd come to me with one IVF failure, non-consummated marriage, 6 years. We just took her baseline. She didn't allow me for a vaginal inspection. So under anesthesia, I had to take her for a hysteroscopy. We did a vaginal dilatation, cervical dilatation, only as much as an endometrial curette could go. We took the sample, we sent it for routinely, I sent it for histopath as well as TB PCR. She came out to be TB PCR positive. So we also need to rule out chronic endometritis as one of the major causes.
So I think Dhruv, if you can add something about the findings of hysteroscopy, especially with 3 failures, I think hysteroscopy is something which is required. Yeah.
Pre-op evaluation is the most important. X-ray recommends 3D ultrasound. And I feel most important is to get it done from the right place. We don't require paragraphs of unwanted information. We require exactly what it is. Like adhesions, fibroids, polyps. We have had just pre-op hysteroscopies. Nothing is there. Just a pre-op hysteroscopy. Endoscopy, we find fibroids inside.
And so many other factors, right? So what is the commonest thing that you see in an RIF patient? So other than the embryo, what all are you going to evaluate?
I think Asherman syndrome is very common in such patients with repeat adhesiolysis, and especially subendometrial PRP has become very relevant, where patients who have probably failed multiple IVF cycles and you've done an endometrial scratching, subendometrial PRP may be offered for a lot of these patients.
So great summing up of everything that we should look, and I like the fact that everybody is emphasized on going back to basics, and like Sargam said that you can't not look at the thyroid and the vitamin D and all that also. So how do we decide whom to blame, whether the endometrium, embryo, anatomical factors, what is like your protocol for that?
So I think Venitus showed us very nicely in 2008 that when you need implantation, you need 3 things: egg, sperm and uterus. And I'm sure all my colleagues will agree that by far the most important parameter for implantation and success is oocyte quality. It's usually 80% for the eggs, 10% sperm, 10% uterus. So I think focusing on egg quality with individualized stimulation protocols may be your first targeted treatment approach for patients who have already been
Yeah, but Dharam,
done
again,
baseline.
initially also when we were thinking about RIF, we were only and only thinking about embryos. I think now is the time, because we see all kind of complicated cases. We need to focus on the other factors also. So anybody on other factors, uterine factors?
Immunological factors. Before that, I would like to point out about ERA, that is endometrial receptivity
Yes.
assay, as well as the sperm DNA fragmentation.
Very important,
Because
yeah.
these two factors are most important. Many a times we see, because of endometritis, the endometrial blood flow is pretty low. Because of that, receptivity is hampered.
I know Ritu has a lot of experience on ERA. So what are your comments on ERA and the use of ERA for IVF?
So there was a time when I was doing a lot of ERA, was getting a good result, but then after there were a lot of papers and a lot of randomized controlled double-blind studies that started coming in and started saying that the era of ERA is over.
ERA is out of ERA, right.
So I've kind of curtailed my use of ERA in my practice, and I don't miss it.
So any of the experts have any say in what would you do other than focusing on the embryo, and what about ERA? Anybody who wants to add on?
See,
I think there's a DICE panel also that we can do for chronic endometritis before thinking about ERA. So DICE panel kind of helps more than doing ERA in patients of rectal.
So ma'am, you're saying something.
Yeah, no, regarding ERA, I think if we have had patients of like 5, 6, 7 failures, in those cases sometimes I do go back to ERA, because I feel ERA, the time, there's no selection of patients. By the time we will get that answer that this is the particular patient for whom you should do ERA and it will benefit, I think we don't know that yet. So yeah, when I'm helpless, when there are so many multiple failures, I do use ERA in those patients.
And I think most of the times it comes pre-receptive. So I know Jatin sir does this, because I had heard him say somewhere that he starts the progesterones 12 hours earlier. I think Dharam might talk about it, because most of the times it's pre-receptive. So even if you don't do it, you can maybe do something like that.
I think experience tops evidence. But
Yes.
I think you're talking from experience that sometimes when nothing works.
I've had a patient now post-receptive 2 days, 48 hours. I'm
Oh.
like really confused right now ki whether to actually follow that or not to follow it.
It's
So,
very
I don't know.
tricky.
I'll take my call when the ET comes.
I think all of us can definitely agree that what we are waiting for is ERA in the same cycle. The biggest problem is that the biopsy you do may not represent the receptivity in the following cycle.
Yes.
And so what we really need to focus on is getting an ERA which you can use in the same cycle.
Yeah.
How long is that report valid? It's a real question which we don't know whether to repeat it after 1 year. If 1.5 year patient comes with a report and you want to believe that.
Yes. And I think Ritu spoke about DICE panel. Anybody about that? Anybody can put light on that? DICE panel. Yes, it's similar. Basically, chronic endometritis. Anybody wants to talk about it?
Okay.
We do a lot of DICE panel.
Yes.
A biopsy can be taken during hysteroscopy or even otherwise after doing a sequential estrogen plus progesterone preparation at the same time when we are doing ERA, and that would be assayed for that would be cultured for bacteria.
Absolutely.
Not the good lactobacillus plus even the bad bacteria. Also in our country for TB, and there are even immunohistochemical.
And for plasma cells. For plasma cells,
It's CD138. CD138 is something which is...
NK, plasma cells and CD8.
Mukesh sir, BCL6 is endometriosis.
Yes, yes.
CL6 also is
And
studied.
CD156 for
And NK cells, I think.
NK cells and
TNF.
CD138 is the gold standard.
Yeah.
Okay,
So Alice plus DICE, basically
Yes,
it's a combination.
yes.
And chronic endometritis is one common cause in India, probably, I feel, for RIF. And often, if you really resort to investigative modality, it is fine and then treat the patient. But you can simply put the patient on antibiotics for 21 days.
But a
And
lot of patients
ciprofloxacin-
do very well with that.
Ciprofloxacin is the drug of choice, probably, I think. And if you just give it for 20 days, I think that will suffice though.
Yeah, I think
Yes,
Yeah, I
yes.
think we have.
I think
Anybody
second where
about...
experience speaks over most papers, because most of the European guidelines, they come based on their data, their countries, which are probably cleaner, and so that's why chronic endometritis may not be a big problem there. But considering Indian subpopulation, I absolutely agree with my seniors. We're probably giving antibiotics for a few days if the patient has that RIF, and if you suspect it on hysteroscopy, may be beneficial for a lot of patients.
And what about microbiome profiling? Anybody?
So ESHRE currently doesn't recommend it, and I'm sure the last ESHRE that we attended in Denmark, Copenhagen, had this beautiful paper where this, I forgot his name, but a French gentleman showed his study where they had collected 20,000 samples to do endometrial biopsies from every single patient who entered their hospital premises, and what they came to the conclusion is that it is impossible to rule out contamination because most of the controls that they had, where you had simply air, they had the same exact microbiome profiling. So getting rid of contamination in your microbiome profiling is nearly impossible, and that's why currently the recommendation
So
is
how
don't
many
test.
people do give probiotics now in their embryo transfer? Almost everybody, yes.
Okay, so
Yeah, good point
I
taken.
saw you nod your head. He doesn't believe in it. So
He doesn't? Okay.
I would still give probiotics because no harm. and
Yeah,
it's
I
easy.
always feel it
but,
is the
but I don't
best.
think testing is.
See, I think I would put my points of view. First of all, the IVF specialists should know their job very well. The lab should be, like the gold standard lab with the culture system. What is your KPI? How good quality embryo you are getting? Whether there is fragmentation or not? Blastocyst culture, blastulation rate is how much? What is your success rate? All those things are very important before we discuss all this, lot of those newer things.
So we
With
assume
respect
we are
to,
normal.
we are assuming that we all are at par and doing the same thing. Then era, I think, came and went away because I have never believed in it, and I don't think there is a 1 or 2 hour window for the embryo to implant. It is a lot many hours where if the progesterone, so that test has gone away. With respect to microbiome, Dhaval rightly you told that contamination is there, and we don't know on which day of the cycle, which phase of the cycle, which microbiome is required. Empirical use of antibiotics I don't recommend because you are killing the good lactobacilli also, and you are causing the vaginitis by giving your antibiotics. So earlier there used to be lot of semen culture reports, antibiotic to the men, based on the wrong reports of seeing WBCs in the semen, which used to be actually premature sperm cells or maybe macrophages. So we have to be very judicious in use of antibiotics, and maybe hysteroscopy findings. If they are matching with chronic endometritis, then go for the immunohistochemistry test, and if that shows, then use it definitely. And thyroid, definitely all the patients should have thyroid test. If required, anti-TPO antibody.
Subclinical hypothyroidism is very
even
high.
You
in
like to keep
India.
the TSH in those patients 2.5 or below that, and vitamin D. Every patient on my first day of the visit receives vitamin D. Then based on the report, either it is monthly 60,000 or full dose of 8 to 12 weeks. So vitamin D is must.
Yes. So next question.
So Sunita ma'am, do you think that any genetic causes of RIF should be investigated? Are there any tests to be done? Particularly in this case where it was a high maternal age?
Depending on about her husband's age also. If he
Probably,
yeah,
both of them
probably.
Yeah.
So in his case, we should do DFI and karyotyping if there are so many failures. So if there are mutations or to find out that you can do karyotyping for both partners.
Shruti, do you really believe that karyotype will be useful for RIF?
So if there have been more than 2 failures, it does warrant to get a karyotype tested because it re-emphasizes the need of PGTA and checking and putting euploid embryos. Though not that common, but if you're doing a plethora of tests, RIF, I think karyotype definitely is one test which needs to be done.
Abnormalities like aneuploidies and all will, or translocations will lead to
Karyotype should be advanced karyotype testing now. Plain simple karyotype is not really good. Microdeletions, most of our microdeletions are something which need to be investigated.
Yes.
So what I'd like to add in this particular category, especially patients with advanced maternal age where genetic testing is being spoken of, it's very important to remember that a lot of these women will have a very poor ovarian reserve, and the current overemphasis on PGTA, in my opinion, is incorrect because a lot of these patients, when you try to culture, they may not reach blastocyst stage. So if a patient, so you have to individualize depending upon the number of oocytes retrieved and the number of embryos you have. If the patient has only 3 oocytes and you've got 2 embryos, I don't know if I would try to grow them till blastocyst to offer a PGT. I would definitely consider doing a fresh transfer because I believe
unless it's a different story.
No, but still, every embryo counts, right? In your experience, I'm sure you know patients have failed the first, second, third, fourth, doing the same thing, 5th cycle, she's pregnant. So sometimes it's just chance and probability, and giving her, trying to grow to blastocyst and having no transfer gives her a 0% chance, whereas doing a transfer with a
So
cleavage stage embryo gives us some chance.
sometimes we can maybe disagree also, because sometimes you want to pool the embryos, then maybe you have 4 embryos, 5 embryos, and then grow them up. Because with repeated failures, I think the scenario changes a little bit.
I think the time taken to conceive is also very important.
You know, the other day I had a patient with poor ovarian reserve. They had done day 3 biopsy, and 2 euploid embryos had been put in already, and she's had failure. So also you can damage the embryo while doing the biopsy. So
Because
even though your report may come normal,
Cell
that
stage.
embryo may have been damaged. So I think what I agree with him that we shouldn't rush into PGTA, and today non-invasive is here. You know, we are doing non-invasive. The only thing is the corroboration has not yet been evidence-based, but I think it will.
Ma'am, you all have done a
gradually
lot of
change.
studies on
We have done
NICS, so-
non-invasive, and our corroboration is about 85-90%. So I think in these type of patients, you know, where you don't want, there's no monogenic disease or anything like that, you can do non-invasive so that you don't damage, at least the damage part
We
of the
still are,
embryos.
like in some cases you don't have a choice, but you have to do it.
Day 3 embryo biopsies, anybody is doing it? I don't remember.
No,
Who
no,
had-
ma'am, I don't think most of us are not doing
like
it.
taken aback.
Yeah.
We'll go to the next question.
Hatching, is anybody doing laser assisted hatching for RIF? Do you all believe in it?
With patients with thick zona, we have tried it, but there's no evidence, and currently it's not recommended by ISHRI.
There's argument in favor of PGTA saying that it is as good as hatching. What about embryoscope or AI-based tools? Any of you are familiar? I know Pfizer is going to tell us a lot about AI. But any particular tool that you all use?
We've just started using a tool called Embryo 8, which does assess the embryo basis certain parameters. It's yet to be corroborated with the genetic analysis. I mean, whether it gives us per blastocyst what is the probability of it implanting.
So you do that for
No, it's too new to
Too
kind
new.
of, but we've started doing that.
But I think AI is into the market, and I think eventually we all will start doing it. Yeah, Ritu, you were saying something.
Yeah, Nandita ma'am.
Sheetal, there is a AI tool which is with the embryoscope now, and which actually gives scores to the embryo 0 to 10. It's called the KID score, and depending on that we do it. So you know, we've done a study where if the blastocyst is high scoring 8, 9, 10, then even it gives us a score of day 3 embryos also. So to do 2 day 3 of which are very good embryos of a good score is equivalent to 1 blastocyst. So I mean, there is AI in the labs now for the past 6 years, and it has been used for oocytes, for embryos, and even for sperms there is a program now which actually picks up.
So I think the most exciting area of artificial intelligence will be sperm selection and doing automated ICSIs. But my fundamental problem with the embryoscope is that it relies on morphology, and I'm sure everybody will agree that morphology is not the most reliable. Very often grade 1 top quality excellent embryos don't implant, and seemingly bad embryos do implant. So the embryoscope may give clinicians an order in which you go ahead and transfer those embryos, but it's very important to counsel patients that just because the best selected embryos did not work, it doesn't mean you throw away the others. There's a very good chance that the other not so great looking embryos may still work. Because
I beg to differ. I beg to differ. No, because AI doesn't only pick up the morphology, it's the time of cleavage, everything, the number of nucleuses which are there. There is a lot more than you just think. Morphology, yes, when the embryologist sees it, but when your machine does it, it's way beyond morphology, way beyond morphology.
You can't match the machine, I agree. So many things that we can actually figure out.
However, recently there was a study in Fertile Studies which said that the embryologist chose better embryos than the AI. So you know there will always be two sides to a coin. But this is a published study that was there.
Still, I think human eye is trumping over AI so far. We've spoken a lot about endometritis, but when you look at the endometrium, what else do you want to look? Like more in detail with regards to a receptive endometrium. Is there anything any one of you all would like
I
to
think
add?
the endometrial thickness, yes, but more important is the characteristics of the endometrium. So it's important to look at the hyperechoic fluffiness of the two lateral walls of the endometrium, and if the total seems to be more than 50% of the total endometrial lining, those patients have a more favorable chance of implantation because it indirectly indicates good blood flow and good receptivity. So not just thickness but also characteristics of the triple line endometrium are very important.
I agree. There was a very large randomized control trial which was done with euploid embryos with ART in Dubai, in UAE, along with Dr. Barasata. and they have published these results saying that the thickness does not matter as much as the morphology of the endometrium matters. They even refute the importance of endometrial blood flow. They just say a good trilaminar, morphologically good endometrial lining in the uterus suffices for your success rate.
Ankesh, do you think hysteroscopy for all is a good strategy?
Absolutely. Absolutely.
For all the patients from the first time, like the first IVF
For RIF, I think, yeah.
Yeah, for RF, for definitely yes, and one hysteroscopy is definitely mandatory, I would say. I mean, if the patient's had a cycle at your center and she doesn't succeed, you fail, she will definitely go to the second center and they'll hear that ye kyun nahi kiya tha. That's the first thing. Also, what Dharam said is, along with the triple line, the blood supply, the color Doppler is mandatory now. Even if you're doing a basic I know the topic is about IVF, you're doing a basic planned cycle or an IUI cycle, or you're doing any form of sonography for follicular monitoring, color Doppler is gold standard. You have to know your RI/PI values. The circumferential 3/4 of the follicles should be covered by the high PI zone. Also at the subendometrium, you should see a blood supply over
Ankesh,
there.
I support this because sometimes what happens is that like everything looks perfect and the blood flow, the Applebaum score is very, very poor. So yes, it is an adjuvant, it is not a mandatory thing, but I think we have to take all the things in consideration.
Even if someone doesn't know color Doppler, if they just know basic transvaginal sonography,
Yes.
if they have the color button and they just know the values of what to check, it's enough.
Yes. Yeah,
I feel that when we are doing hysteroscopy, along with that laparoscopy also should be done, because you are seeing the cavity but you are not able to see the tubes. So if there is hydrosalpinx or something, then also just putting a probe, I think that should help in these cases, because these patients might have done laparoscopy way before the procedures. So I think,
and there's also something called as microscopic endometriosis also sometimes, which is there.
Any role for checking medical cofactors like thrombophilia, Sabra? You are not.
I routinely do a HbA1c for all my patients because we of late started seeing insulin resistance is one of the major causes at the level of the mitochondrial inflammation, and oftentimes we realize that an undiagnosed, unexplained infertility or an implantation failure may be an undiagnosed and untreated mitochondrial inflammation. So HbA1c is something that I routinely check. I also check for thrombophilia, the Appler syndrome.
Yes.
So anybody wants to, Shruti, would you like to say what all do you do in your Appler or whatever thrombophilia profile that you do?
So I don't do it as routinely, but yes, in a case of RIF, I would be doing the basic APLA, lupus anticoagulant, beta-2 glycoprotein, would be checking for anti-cardiolipin, would also do a ANA, maybe anti-TPO, anti-thyroglobulin, and this is anti-cardiolipin, correct.
Yes. So one of the experts, ma'am, you said something about CD138 and BCL6 and CD156. Ma'am, any role for immunological testing of the endometrium and then thymosin alpha and all those other immunomodulators?
See now, all the other immunomodulators, I was just reading actually before I came here. And none of the evidences, there are no RCTs which are actually saying that these are safe. They show potential. A lot of people are using it. I have used it occasionally on a few patients because you have no answer. You don't know what to do. And the patient just looks at you and you need to do something. So you do try. So I've tried tacrolimus in about a couple of patients. I have used thymosin in a couple of patients. I've used lit in a couple of patients. But with a lot of not fully convinced that it should be done.
Ma'am, I've heard that in endometriosis patients that is where the TH1, TH2 balance is kind of shifted, and that is where, you don't agree? You agree, okay. Yeah.
I think in RIF patient we should investigate thoroughly.
Yes, yeah.
All factors, immunological factors, thrombophilia,
So
acquired,
but I think it is
inherited,
easier to
anatomical
just give
factors, hysteroscopy, 3D,
Patient budget, sir.
sonography, and every
So
damn thing.
budget-
But I don't know how much it is going to help.
Yeah.
That is something which is extremely difficult. But a case of RIF is there, proven RIF, patient has gone into toss.
Yes, yes.
That's
So
something that
Sita-
you need to investigate the patient thoroughly. Whether you can offer any therapy or not is a question by itself.
Adenomyosis.
Yes.
Adenomyosis, yeah, it
Big
works in
factor which may
endometriosis.
end up playing a role in a failed implantation.
Yes. And
she-
in fact, please go ahead.
With respect to this,
So I was just saying, we have such fancy tests, and Nandita madam mentioned tacrolimus and all these things. Aren't we, we have all these medicines, but aren't we already mandatory giving IVIG and intralipids to all our patients as protocols on the day of the transfer, 15 days after transfer? I that day heard of a protocol which I was quite impressed of. You give IVIG, you give intralipids and IVIG alternating every 5 days from 5 days before the transfer, on the transfer day, after the transfer, on the beta HCG, on the heartbeat scan. So there's no stone left unturned, I feel, with the amount of, we can use medicines and do blood tests. So with IVIG and intralipid, people are already playing the immunomodulity game.
Yes.
But IVIG and intralipids are not entirely safe. There's enough cases which show that they can cause hepatomegaly, splenomegaly.
This is what I was saying.
There is no evidence currently that IVIG or intralipids work, and it is not to be used as per SHA guidelines, and it does have side effects.
Yeah, okay.
There are SOBO doctors on the panel, western side doctors, we central side people are feeling very poor. Your patients are ready to do everything.
I think with respect to this immune modulation in RIF patients, I think first of all RIF affects only 3 to 5% of the patients if the embryo is euploid, you know. And whenever you are faced with the RIF, you have to thoroughly investigate, where we have discussed all this acquired thrombophilia, hereditary thrombophilia DNA panel, anti-TPO, then all these HbA1c endocrine disorders, ANA test also. If ANA is speckled, I have had patients who had ROLA positive, and in fact in 2012, the tiniest baby of the country who had pacemaker was our patient, IVF patient only, who had ANA positive, ROLA positive, and cardiac arrest. In twin pregnancy, one fetus died at 26 weeks, another taken out at around 27 weeks at Kogilaben, and then we put the pacemaker. So we had to do this 2D echo, fetal 2D echo from 16 week to 26 week. Every week we had to do, and we have to give immunoglobulin to IVIG to these patients.
Sir, we can definitely invite you on the high risk pregnancy panel also now.
And another thing is, all these drugs immunomodulatory, either they are suppressive or they are stimulating. So you cannot use it randomly, combination, and confuse the immune system that I'll give this also, I'll give that also.
Okay,
you have
now
to judge what you want to give and what is the profile of the patient's blood test.
Say something. Yeah.
Actually, you're right, because there is a genetic test which is available now.
Yes.
It's very, very expensive, but yeah, C1, C2, 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 if that is the type of genotype that you have, then the C2, C2 will benefit from it, but C1, C2 will not benefit from it. But that becomes too expensive. The patient is spending 3-4 lakhs for it. So yes, that patient who can afford it, there are tests available today, and which you can actually specify which patient requires what. But till, if you are, you're handicapped, because if the patient doesn't want to spend that kind of money, yes, all of us are using, whatever we may talk here, we are all using steroids, we're all giving intralipids, for these patients, because we have to help them in some way. So thymosin is probably the only medicine which actually modulates it and brings it to normal.
Even TH1, TH2 balance.
Yeah, with the Treg cells, but we don't have enough RCTs or safety profile of thymosin. So actually that is the only drug which actually doesn't increase or decrease. It just modulates it and makes it perfect. So yes, I do agree that you do require modulation, but we don't have anything in our armamentarium right now which is proven for it.
So what is your favorite
thing, can I just mention
Yeah,
one more test I would like to
choose
mention?
a few, each one of you all can answer.
For these RIA patients, sometimes I do TNF alpha test. If it is high, so I have used thymosin alpha in almost in 18 patients till now, and 14 who had TNF alpha raised. Only 14 results are there till now, 4 are awaited, all are positive. So I don't know what will be how to take it. TNF alpha.
We have a code.
So if TNF alpha is raised, I have used thymosin in all these 18 patients, 14 beta HCG already done, ongoing pregnancies, 1 delivered also, and all have successfully done it.
Yeah.
In fact, one of the patient I had put in Malad Medical who was 46XY, Swear syndrome. 4 donor cycle failed, then she came to me, I did TNF alpha, it was positive, then we gave thymosin
Okay,
alpha.
so if TNF alpha is positive, maybe we can consider giving thymosin. Now next question, favorite adjuvants? I think we'll start with Dr. Joglekar. What is the churan that you give? What do you prefer? Do you like a combination, or what's your
Anything
take?
we've not mentioned also, sir, you are free to mention.
Free to add.
All whichever is available on the screen.
Ideal patient does everything. But sir, if you just have a very, very poor patient who only 2-3 things you can choose.
So
your top 3.
top 3, top 2, whatever.
Everyone has one adjuvant. And we give all the adjuvant.
Everything for everybody.
All the adjuvant.
Shruti, yeah.
So sildenafil, L-arginine for sure,
Yeah.
and then depending on the other factors, maybe PRP, intralipid.
Scratching anybody?
L-arginine and aspirin.
No scratching?
No scratching, Hera?
Oh, that's
Oh,
included.
there
Yeah.
is, there.
It's no scratching also.
3, you can choose 4, 5, whatever. Sargam, you.
I always give coenzyme Q10, active form of coenzyme Q10 ubiquinol.
Makes sense.
Along with L-arginine because that releases nitrous oxide and proanthocyanidine if you talk about the top 3.
Okay.
Definitely L-arginine, sildenafil, and definitely while even a scratch at sometimes. CGSF, I think you can even use it intrauterine. Also, you can use it as subcutaneous. I think it's worked for us.
How do you use it?
Sheetal, I can't tell you. This is every patient comes back with severe. What adjectives I've heard, doctor. I feel my body is being crushed by somebody. My entire body is finished. I can't get up from the bed. Nobody has not complained of bone pain after CGSF. Subcutaneous.
How many times do you give it?
Definitely before the transfer, I would say
Once
once before, but once for sure.
Once for sure. Dhruv? All of it.
I like the way he said all of it. No discussion.
Yeah, he'll be like hysteroscopy and scratching for sure.
Yeah. Oh, let them speak.
Yeah, so we'll finish. Radhika next.
Almost all.
Almost all? Oh, very rich patients you all have.
I would also use all of these, but beside that I use one product called Seminova.
Seminova, okay.
It works on the mitochondria of the cell wall for the male as well as female partners. So before we take patient for IVF, we put them for 3 months on Seminova. It is a product which is quite, it's organic product.
But isn't it more for egg quality rather than RIF?
Yes, it is. It is.
Right. Okay. So you believe that egg
So
quality
obviously
is...
you improve the sperm and the oocyte both.
Okay.
And I have seen the number of patients. Some I have considered with us, but some I think I have given in the patient who have come from abroad and their IVF cycles were also successful. So I quite believe in that Seminoma powder, which is it worked for my
given
patients.
for 3 months.
We have to give it for 3 months.
Yeah.
It's 4 scoops twice a day and continue for 3 months. I don't have a detailed documentation with the investigation that this has improved. No, but the success has happened. I really can't.
Ritu, what's your take? What's your choice?
Are we talking about adjuvants generally or
Whichever
in
are-
RIF?
RIF.
In RIF, low molecular weight heparin is something that I would prefer over everything
Very,
else.
very honest.
Sir, your take?
Just want to add my experience.
Yes.
L-arginine we used and stopped. Sildenafil we used and stopped. Endometrial scratching we used and stopped. Intralipids, query. And GCSF we used and stopped. I think most of the things we have used and
So
stopped.
as per the ESHRE guidelines, nothing
None of
is
them are
recommended. It's your call what you want to use and what you don't want to use. So yes.
Anybody doing intrauterine HCG infusions before embryo transfer? Yeah.
Yes, we do. Around
Yeah,
72
because that is
hours.
Something where they are ambiguous and they are saying that it may work.
Around 72 hours prior.
Yes.
500 to 1000
Yes.
units of SCG to be injected.
Yes. Yeah, I think
the
we've
end of the-
So I think we've already spoken enough about thymosin alpha. I think we can ask one question to everyone that if there is one investigation that we can do in an RIF patient, what would be your choice and what would be your pick for any RIF patient? Maybe we can start with the experts to summarize a little and then
Few last words for the
Few last
RIF patient
words
who comes
because-
next to all of us.
I think I am very confused and I don't know how to treat RIF. Basically.
All of us
I
are
don't know what happens, I'll end up in a-
very, very confused.
I do all the immunology for antiphospholipid antibody. I do for thrombophilia, and I do immunological tests also.
Yeah. Yes. Sunita ma'am?
Lifestyle modification is very, very important because this is a main factor which is causing infertility in everyone.
Yeah, I think we ignore
But
the
that
small things
ignore
like
that
stress.
cause, stress, and both partners are working. They have different schedules. They come home, females especially. They come home, they cook, and they sleep at 1 o'clock, get up at 4 o'clock, and they're going for job. So that is causing a lot of hormonal imbalance and leading to all these things.
Smoking also.
I think the most important thing for RIF is to always review the patient's previous stimulation protocol, because sometimes repeating the same stimulation protocol again and again may not make sense. So maybe changing the drugs, changing stimulation protocol may be very important.
Most important, patient is financially and emotionally completely broken. So we have to first give emotional support, and whatever test we are choosing, we should choose those tests. Those are financially better for us.
Yeah, so I think we had a very
Fantastic.
Yeah, I still believe that euploid embryo by doing a PGD is the first thing we should do to prevent this thing. I still feel that way.
One thing ना that laparoscopy ना बहुत कम करे तुम लोग youngsters. Because there's a lot of COX and PCR may not come positive. So दो cycle failure में दो patient don't agree now because all of you are saying only hysteroscopy. They say अरे ये तो कुछ पैसा नहीं. But scopy is a very important part. You may laparoscopy is a even WHO guideline में laparoscopy has not been mentioned. So that is, and second thing I have found lot of, because you may all land in trouble because many of them come to me with PGD done first cycle. ये क्या है? How can you do like that? There will be a litigation on you. अरे normally advocated by H3 guideline, 3 failure हो गया, 2 failure तो PGD करो. ये PGD करके आते हैं.
Yeah, one more thing.
Then I tell them, बाबा अभी ये टाइम PGD के बिना डाल देंगे. I mean, what is this? So you have to be, no, listen, it's not a laughing matter. Now the data will start getting put in. And then there will be litigations and license suspension. So you have to be careful. You can't break the protocol. You cannot. For financial gain, you cannot break the protocol. You have to follow the protocol. If there's a 2 failures or 2 miscarriages or even age more than 35 is a debatable thing. So you have to be careful because it may land all of us in trouble. And they'll knee-jerk reaction, they'll ban it unnecessarily. It's a wonderful test it is there, technique is there. By doing out of turn, you may get it banned.
And one more thing, positive TB PCR in a patient who is already treated with anti-COX therapy has no meaning. It need not be treated again. And if you really want to see active tuberculous bacillus being present there, you may have to do RNA TB PCR rather than DNA TB PCR.
So great, I think no more words after words from the bosses. So I think we have reached the end of the panel. Thank you for an amazing panel exercise.
Thank you.
Thank you everyone.
Can you all come on stage? Ma'am, so.
We would like the experts to please felicitate the moderators and panelists for today's session, please, sir.
Thank you so much, ma'am.
Excuse me. Excuse me, ma'am. Hello, sir. Hello, ma'am.
Just take a picture. Please come. Please come.
Hello, sir.
दोनों सर के प्लीज काम ना दोनों सर मनते हम और मैडम
Yes. One more.
We request the experts to please felicitate the panelists.
Hello. Could the experts please stay back? Nandita ma'am, please stay back. Mukesh Agarwal sir, Sunita madam, Gadam sir, if you could please stay back on stage, we'd like to felicitate the panelists.
Ashlesha Sankhe ma'am.
Excuse me, sir. Excuse me, ma'am. Hello, ma'am. Hello, ma'am. Excuse me, please.
Ritu Hinduja ma'am.
Radhika, I think I know you.
Uday Joglekar sir.
I've heard a lot about hello, sir. Hello. Say, how's your dad now? मैं तो खड़ा रहता हूँ।
Hello, sir. Shruti Parekh, ma'am. Dr. Dharam Shah.
सुन ही नहीं रहा है।
Dr. Sargam Soni.
Oh, sorry. Sorry.
Dr. Ankesh Sahitya. Dr. Radhika Shenoy. Dr. Dhruv Goyal.
क्या बोलता है? Good.
Dr. Shrutika Thakkar. Dr. Sheetal Savankar.
We request Dr. Bela Bhatt ma'am and Dr. Jayanti Kamath ma'am to please felicitate the experts for today, please.
मैडम थोड़ा बैठ जाए ना। हेलो मैडम।
Dr. Nandita Palshetkar. Dr. Mukesh Agarwal. Dr. Sunita Mori ma'am.
मैडम सॉरी मैम निकल गया फिल्म करने।
Dr. Mohan Gadam ma'am, sir.
सर नमस्कार, मेरा पूरा सैटरडे का पार्टी लगा दिया।
With this, we finish off the first session. We request Dr. Nitinsha sir to please come on stage and present the award to Dr. Nandita ma'am for the Champion of Fertility Award. We request Dr. Rajendra Saragi sir to please come on the stage.
Big round of applause, please.
The IVF champion Rohan Palchetkar.
We request Dr. Rishikesh Pai sir to please come on stage to receive the award for the AFG Champion of Fertility Award. We request Rishikesh sir to please accept the award for Dr. Rishma ma'am also.
Hello sir. Hello sir.
With this we conclude the first session for today.